are absolutely in the right place. Before we jump in, I want to give a massive shout out to Dr. Asifullah KMU IMS Kohat for inspiring the foundational structure of today's clinical overview. All right, so here is our clinical roadmap for today. We'll start with the clinical blueprint, move on to spotting congestion, then tackle acute decompensation, and finally, formal diagnosis. Okay, let's jump right into Section 1, the clinical blueprint, focusing on pathophysiology and general features. The absolute most crucial thing to grasp right off the bat is that heart failure fundamentally presents in two major ways. First, you've got forward failure, which basically means low cardiac output and poor tissue perfusion. The heart just isn't pushing enough blood out. On the flip side, you have backward failure. This is where fluid literally backs up like a clogged drain, causing massive systemic congestion. When you look at the mechanics, it's kind of like a giant puzzle. Systolic dysfunction is strictly a pump problem. The heart's contractility is impaired, which drops the ejection fraction below 40%. But right next to that, diastolic dysfunction is a fill problem. In this case, the ejection fraction is actually preserved, but the heart walls are stiff. And we absolutely cannot forget the Frank-Starling mechanism. Basically, up to a certain point, increased stretch equals increased snap. But when that mechanism gets pushed too far and fails, the whole blueprint just completely falls apart. So how do these mechanical issues actually show up in a patient? Well, think of the mnemonic phases: fatigue, activity altered, congestion, edema, and shortness of breath. Backward failure gives you those venous blue signs, right? Things like weight gain and elevated JVP. Forward failure, on the other hand, drops into the arterial red category, reduced output signs like a fast heart rate and cool hands and feet. Actually, here's a massive pro tip for you. Always separate the subjective symptoms a patient tells you about in their history from the concrete signs you physically uncover during your exam. Moving right along to Section 2, spotting congestion. We're going to look at left-sided versus right-sided failure. Before we get into the anatomy of it all, I want you to keep these major clinical red flags in the back of your mind. We're talking dyspnea on exertion, paroxysmal nocturnal dyspnea, or PND, pink frothy sputum, elevated JVP, and bilateral pitting edema. Honestly, if you're seeing these, you are definitely looking at fluid backing up in the body's pipes. Let's break this down with a super simple rule, the L for lungs principle. Left-sided failure causes pulmonary congestion. Because that left ventricle just can't pump effectively, blood backs up right into the pulmonary veins in the lungs. So what does the patient complain about? Dyspnea on exertion, orthopnea, which is struggling to breathe when lying flat, and that classic PND. And on your physical exam, you're going to hear bibasal fine inspiratory crackles, notice them breathing fast, and maybe even catch an S3 ventricular gallop. If you looked under a microscope, you'd literally see heart failure cells. Those are hemosiderin-laden macrophages inside the alveoli. It is essentially the lungs drowning in fluid. Now flip that around, and we have the R for rest of the body principle. When the right ventricle gives out, fluid backs up systemically into the vena cava. This creates major upper body traffic jams. You'll see elevated JVP, positive hepatojugular reflux, and tender hepatomegaly, which makes the patient feel full really quickly. Lower body backups show up as that classic bilateral pitting edema, or sacral edema if the patient happens to be bedridden. And here's a really key point. As we see with cor pulmonale, chronic lung disease can trigger pulmonary vasoconstriction, which leads straight into this right-sided failure. All right, Section 3, acute decompensation. Let's cover flash emergencies and progressive decline. Picture this scenario for a second. You get paged to the ER for a sudden cardiac event. A patient with known heart failure has violently crashed. What exactly are you looking for the second you walk into that room? Well, acute decompensated heart failure is a pretty terrifying flash emergency. The patient comes in with sudden, severe breathlessness, a persistent cough, and just this intense anxiety driven by a massive sympathetic surge. When you examine them, you're hunting for flash pulmonary edema. We're talking diffuse bilateral crockles, profound hypoxia, and that textbook pink frothy sputum. But here's the catch. You have to watch their hemodynamics like a hawk. Early on, they might actually be hypertensive as their body tries desperately to compensate. But late in the game, they crash hard into hypotension and cardiogenic shock with altered mental status and cool, clammy skin. You literally have minutes to act. Now, if a patient survives one of these acute episodes, but their disease keeps getting worse over time, they go through what we call the 4 relentless nodes of systemic exhaustion. That's functional intolerance, metabolic cachexia, hemodynamic instability, and finally, terminal signs. When we map those nodes onto a decline curve, it really illustrates this relentless journey into end-stage systemic exhaustion. At node 1, they have severe functional intolerance. They're breathless even when they're just resting. By node 2, cardiac cachexia sets in, which means profound weight loss. And node 3, their hemodynamics are just permanently unstable. They've got a weak pulse and chronic hypotension. And then node 4 brings the terminal signs, massive intractable edema and Cheyne-Stokes respiration. It's a steep downward curve, and it carries an incredibly high mortality risk. Which brings us to section 4, formal diagnosis. Let's talk about standardized grading and criteria. First up, we use the New York Heart Association, or NYHA, functional classification. This is so important because it gives all of us in healthcare a universal language to grade a patient's physical limitations. It ranges from class 1, where they really have no limitations, all the way down to class 4, where they have symptoms even while at rest. Think of this classification like a staircase tracking the progression of the disease. At class 1, there is structural disease, but ordinary activity doesn't cause any symptoms. Take a step down to class 2, and you start seeing slight limitation. Class 3 is a big drop. Even less than ordinary activity causes symptoms. In class 4, that is the absolute bottom of the stairs. The patient is totally unable to do any physical activity without discomfort. We rely heavily on this grading to figure out how intense our treatment needs to be, to track how they're doing, and to predict prognosis. Finally, to lock in an official, undeniable diagnosis of heart failure, we rely on a very specific mathematical rule based on major and minor clinical signs. To make the diagnosis, you need either 2 major criteria or 1 major plus 2 minor criteria. We figure that out using the Framingham scale. The heavyweights are your major criteria: acute pulmonary edema, neck vein distension, PND, and S3 gallop, and cardiomegaly. Then you have the supporting signs, which are your minor criteria: bilateral ankle edema, nocturnal cough, hepatomegaly, and a fast heart rate over 120 beats per minute. By weighing these out, again, 2 major or 1 major and 2 minor, you take the guesswork completely out of it and officially lock in that clinical diagnosis. So, as we wrap up this explainer, I want to leave you with a bit of a challenge. Next time you step into a clinical encounter, ask yourself, how rigorously are you investigating the real root cause of congestion in your patients? Will you be able to flawlessly separate the symptoms they're telling you about from the actual physical signs you're uncovering? Mastering that separation is the true mark of an exceptional clinician. Keep learning, and I'll see you in the next one.